Well, hello everyone. Hopefully you had some coffee and kind of woke back up. My name is Neal Duong. I'm a PhD candidate in biomedical engineering from the University of Minnesota and the Visible Heart Laboratories. And I am not a proceduralist or anything like that by training, so I'll be kind of talking through the different tools that I've used as an engineer to help me actually implant left bundle branch area pacing, as well as some of our results for understanding the spatial, electrical, and hemodynamic coupling of the ventricular cardiac conduction system. Here are my disclosures. As many of you are well aware, conduction system pacing has risen in the recent years and aims to activate the native conduction fibers of the left bundle branch, or more historically, the His bundle, to stimulate the heart. And with the rise of left bundle branch area pacing, procedural efficacy and outcomes still differ among centers. So I believe that we can kind of build extra tools to make this better. Modern ventricular pacing therapy has become more popular compared to His bundle pacing due to its long-term lead stability, but once again, left bundle branch area pacing technique can still be improved. And despite many consensus statements, full agreement on the interprocedural metrics, specifically the electrical metrics of success in left bundle branch area pacing, remain stratified. So things that will probably be similar or familiar to you all is cure restoration, LVAT, left ventricular activation timing, and then also R wave slew rate, so the slope of the R wave complex in V6. So when we kind of break this down to a more anatomic level, which is our specialty in the lab, is what are the major contributions to the effectiveness of a left bundle branch implant? And number one is how close are you to the left bundle branch? Your depth across the septum. So as we know, there's multiple fiber orientations that exist within the heart. So you have your RV endocardium, your deep septal, and then your LV endocardium, as well as the health of the substrate itself. So is there left bundle branch alive underneath, or is there septal scar in the area? For the purposes of this talk, we'll focus mainly on the proximity to the left bundle branch and the fiber orientation across the septum. Just a brief dissection. So this is a porcine heart, which we did a dissection down to visualize the left bundle branch. And this is a special case because the heart was diseased. How could I go back? And we were able to kind of visualize the left bundle branch trunk as well as the anterior and posterior fascicle in this heart as the myocardium turned to translucent. So once again, the objective of this is to highlight the spatial, electrical, and hemodynamic coupling in left bundle branch area pacing by visualizing where the lead is in the septum, the electrical metrics that we use to determine if we leave the lead in the septum, as well as using a PV loop catheter to get the acute hemodynamic effects. In this study, we used a canine model, was chosen due to its similarity of its conduction system behavior compared to humans, as traditionally in the lab we work on swine. So the methods can be intertwined into three larger sections. So we have the in vivo implant, where we screwed multiple leads across, the in silico reanimation, so as Paul mentioned before, reanimating the heart so that it is both hemodynamically and electrically active, as well as ex vivo imaging to help visualize the conduction system as well as the fiber orientation. So during the implant protocol, once the leads were in place, we paced at high and low output. We used fluoroscopy to get into place, as well as putting multiple 3830 leads across the septum. This is a very kind of complex procedure, at least for me. And during the process, we used a rotatable connector, so we can pace unipolarly from the lead as we're screwing across to help us get an idea of depth. So in this process, you can see here's the kind of continuous unipolar electrogram that we got. So we can measure current of injury to make sure that we're engaged in ventricular tissue. Paced LVAT for depth. So as we kind of screw across the septum, we paced unipolarly to see the left ventricular activation time. And then also taking periodic unipolar impedance to test if we had perforated. We're also lucky enough to have a 3D fluoro in our lab, so we could make sure that we have pinned the lead location in place in 3D space, as well as get the general anatomy of the thoracic cavity to relate to the leads later on for the 12 lead. Afterward, leaving the leads in place, which required careful dissection, we then recannulated the heart and put it onto the visible heart apparatus. And here you can see views of the left ventricle and right ventricle, showing where we had screwed in the lead helix into the left bundle branch anterior fascicle, and then right where it kind of split off into the Purkinje system. And then here's just a view of the right side. Then we put these into the micro CT. So using different filtering methods and imaging methods, we could localize where the leads are by minimizing the artifact. And here's a distribution of the leads on a kind of a simulated heart. So we could have the cranial caudal direction, the dorsal ventral direction in the canine, as well as how deep we were across the septum. Then, using a lot of the methods that I had developed prior to my thesis, we could use contrast-enhanced micro-CT to actually visualize the conduction system. So here's a segmented example of the canine conduction system anatomy, inclusive of the left bundle branch trunk and its fascicles. And then on the image here is just a 2D slice of the resolution that we can see. So we've kind of gotten better throughout our work here, starting at kind of the 100 micron resolution to all the way down to a 15 micron resolution. So here's just a thresholded image of the ventricular septum, so from the LV free wall in towards the septum. And then here you can kind of see the trunk as well as the underlying fiber orientation that exists under the heart. So describing how these might interplay together would be important for new implanters and some experienced implanters to understand what might be going wrong. So onto the results. Here are our electrical metrics as predictors of ejection fraction. So by normalizing ejection fraction to baseline, we find that QRSD, LVAT, and R wave slope in V6 seem to correlate relatively well. Of course, this is only an N of 5, so we could increase this and hopefully would have more predictive value. But we see that as we kind of go across the septum, each one of these provides a different picture of what's going on in the ventricle, as QRSD may not be fully descriptive of the morphology of the QRS complex. And as we can see here, the R wave V6 had the most predictive value. And then now, when we kind of relate what we see anatomically, so where the lead was in the septum compared to the ejection fraction itself, we find that lead height and depth both seem to contribute to ejection fraction. However, the lead height was more predictive in this model. And this may not be the case in all patients. However, this is a healthy model in which we try to understand these mechanisms. Then we did a multiple linear regression model. So just a simple multiple linear regression model to see if we could use lead position to help predict our electrical metrics as well as our hemodynamic metrics. And kind of the key takeaways that we had here, where ejection fraction was influenced by 3D lead orientation, strongest in depth, and then secondarily by cranial caudal adjustments. And then LVAT was more directly influenced by depth into the septum, which makes kind of sense intuitively, but proving it in a mechanistic sense. If you're closer to the left ventricle, you're going to have a faster left ventricular activation time. And then secondarily by cranial caudal positioning. And then R wave V6 was most closely predicted by lead depth into the septum, and secondarily by cranial caudal positioning. So these are things that implanters are kind of already intuitive doing, but what we can add in a future study of this is to localize exactly where the lead is in relationship to the conduction system anatomy. So optimal left bundle branch area lead placement can be achieved by balancing cranial caudal height with implant depth, both guided by R wave slope and LVAT rather than just QRS duration alone. So in this study, we sought to characterize the spatial, electrical, and hemodynamic coupling in left bundle branch area pacing by trying to match this electrical signature with its relationship to the conduction system anatomy. And then we looked at R wave slope, LVAT, and QRSD as different electrical metrics to look at hemodynamics. We also outline a procedural pipeline for characterizing alternate site pacing, as well as new devices as we start to look at like leadless conduction system and things like that. Some future work. So we're using this as validation for computational models. As you can imagine, this is a very rich data set. So if we do kind of the epicardial maps with the CardioInsight system that we had from the tank, as well as all of the different electricals that we've collected, both in vivo, ex vivo, and in the imaging afterward, then this was a very rich data set for at least ventricular modeling. And then hopefully we can use this as a transfer function for segmented conduction systems. So within the Visible Heart Lab, we have about 800 plus human hearts that are available to us with a varying degree of disease pathology. So using this methodology, at least to image the conduction system, can help us understand how these develop over time. And then kind of finally, working on an electrical metric algorithm for predicting lead success. So what are kind of the thumbs up parameters that we can use, or what are the electrical signals to help us help predict the implant location? So all these different ways that the QRS can present, we need to kind of look at these a little bit deeper to see if we can use them to predict where we are within the native conduction system. Thank you, and I'll take any questions.